just
that
start. Just
okay. So the topic that we'll be discussing today is on immunobullous disorders. Mainly, I'll be talking about intraepidermal and epidermal bullous disorders, which is pemphigus group today. So we'll start with the basic classification of immunobullous disorders, which is on the basis of whether the bulla or the blister it is in the epidermis or it is below the epidermis. So when it is in the epidermis, the main types of conditions are pemphigus disorders, which is pemphigus vulgaris, foliaceus, and etc., which we'll talk about in detail later on. Then subepidermal disorders are bullous pemphigoid, mucous membrane pemphigoid, pemphigoid distortionis, linear IgA disease, bullous lupus, DH, and epidermolysis disorders. So subepidermal and intraepidermal bullous disorders, they are present in different ways. Clinically, they look different, and then, of course, on histopathology, biopsy also they look different. Um, the hallmark of all these immunobullous disorders is the formation of these blisters, which is like these round blisters on the skin. And in the intraepidermal, which is the blister inside the epidermis, the blisters will usually be flaccid, so they'll rupture easily. Um, while in the subepidermal group, where the blisters form below the epidermis, the blisters will be more tense. So they'll be more tense. That is the clinical feature. Then, of course, a biopsy we'll discuss in detail later. So, coming to the intraepidermal immunobullous disorders, which we'll mainly talk about today, is divided. It's basically because of autoantibodies against cell-to-cell adhesion molecules. So, when we talk about the epidermis, as we have discussed in our previous lectures, the epidermis composed of 5 layers, and then the main uh, the main framework, the main foundation of the skin is keratinocytes. These keratinocytes stick against each other via these adhesion molecules. So when the antibodies form against these molecules, the keratinocytes, these cells tend to separate. And when they separate, they move away from each other. It causes these blisters because of accumulation of fluid between the cell spaces. Then there is also immune complex deposition, which also causes disruption in the keratinocyte adhesion. Cells separate from each other and then blisters form within the epidermis. Now, types of pemphigus. There are types of pemphigus. Number one is pemphigus vulgaris. Number two is pemphigus foliaceus. The subtypes herpetiformis, pemphigus erythematosus. Induced pemphigus is because of sometimes drug induced, because of environmental conditions, very rarely because of certain types of diet. Then paraneoplastic pemphigus, where the pemphigus is because of certain malignancies. We'll talk about all of these individually in the next slides. Now, the central to the pemphigus disorders, again, is intracellular adhesions, which is the cells which kind of stick to each other, which the disruption occurs in the adhesion, which leads to pemphigus, which is the basic central pathogenesis behind the condition. These adhesion molecules are adherence junctions, then desmosomes. Among desmosomes, this will be the most important one for pemphigus, which is desmogleins. Then the other ones are plakophilin, plakoglobin, desmoplakin. So antibodies can form against any of these molecules, and which can then lead to the pathogenic blisters. So again, looking at the pathogenesis in a picture format, imagine these are cell 1, cell 2, which is your keratinocytes. Ideally, these are bound to each other. So they stick to each other via these receptors, these molecules, which are your these adhesion molecules. right? So these are your adhesion molecules, these. So when antibodies form, they attack these molecules, they attack these junction molecules, which causes them to go away. So they disappear, they get destroyed, and then the cells float independently. So the cells float independently, the fluid accumulates, which causes blistering in the skin. Right. So this is a clinical scenario which probably you might get in your exam question papers. For example, they might give you a picture of 40-year-old lady presented with these lesions. They might give you a photo since about 3-4 weeks, gradually increasing. Initially started from the oral mucosa, then appeared on the rest of the body. Um, Now the question might be, uh, what is the diagnosis? It can also be what is the cause of the uh, problem? What is the autoantibody involved? So I'll first start with the diagnosis for this typical condition. So this is, we can see in the photos, we see these small blisters, which are the bulla, the blisters which appear on the skin, and the background we see erythematous plaques. So these blisters, we already know it is probably some immunobullous disorder. The age group also usually from adulthood is the most common age for pemphigus, from 30 to 50-year old, and then it starts from oral mucosa. That is also a clue. So blistering can involve the oral mucosa, also the skin. So this is a case of pemphigus. We see very severe erosions in the mouth, and we see flaccid blisters. Then we see crusted erosions. So this is a case of pemphigus vulgaris. Why pemphigus vulgaris? Because oral mucosa is also involved. In the other types of pemphigus, like pemphigus foliaceus, the oral mucosa is not involved, and also the distribution is different, which we'll again talk in the upcoming slides. So this pemphigus vulgaris, let's talk about this. This is the most common type of pemphigus we see even in our clinical practice. It can occur in both sexes. We discussed it's most common in middle age, which is 30 to 50, 60 years of age group. Ethnically, it's actually more common in Jews, but we also see quite a large number of patients from India as well, from the Indian subcontinent. Genetically, this is important for your MCQs. It is somewhat associated with HLA-DR1. Now, the pathogenesis is antibodies against desmosomes. So we discussed these desmosomes which bind the keratinocytes together. When the antibodies attack, the keratinocytes separate, they start floating, and then cause the pemphigus condition. The main desmosome involved is desmoglein 3 in pemphigus vulgaris. It's also extremely important for MCQs. DSG3, and then DSG3, which is mainly associated with lesions in the mucous membrane. If desmoglein 1 is involved, then we'll also get skin lesions. So DSG3, remember, is for mucous membranes, and DSG1 is for cutaneous lesions. If patient has both DSG and DSG1 and 3, the patient will have both skin and oral involvement. So for example, this patient has oral mucosa involvement. So this is DSG3. And then, oral mucosa is DSG1, and then skin is DSG3. Coming to, so another interesting example of pictorial presentation of pemphigus vulgaris, what is going on inside the skin essentially is B cell, which form the antibodies. These, the protease get released and break down the proteins that make up the desmosomes. So for example, these two on both sides are your keratinocytes. So this is our desmosome. Let's say this is your desmoglein DSG. Antibodies form, acantholysis happens. The cells let go of one another, forming the blisters. So this is a healthy skin. This is pemphigus skin. We can see healthy skin, the lower layer, the skins are quite uniformly attached to each other. However, when we talk about pemphigus, the same here and here, the keratinocytes have detached from each other. So we see this extra space forming, which is not in the healthy skin. So this extra space where the water, the fluid accumulates and causes the characteristic blisters. All right. So clinical features, oral lesions occur in 50 to 70% of patients. So this we're discussing pemphigus vulgaris. Oral lesions are most frequent. Then cutaneous lesions can also be seen from up to 30 to 40% patients. These are classic, meaning um, very easily rupturable bulla. Then erosions heal without scarring. So there is no scarring, mainly some pigmentation. So we see these blisters, these bulla, and then we see these erosions. The distribution is mainly on the trunk and flexures of upper limbs. Now, this is a more severe case of pemphigus. We see widespread erosions, very bright red erosions, and then some blisters, some bulla in between. Now, these are very also important for exam point of view. There's two common signs we do in a pemphigus patient. One is Nikolsky, the second is Asmo-Hansen. So Nikolsky is we can see we are applying pressure on the skin. So pressure on a finger will separate the normal looking epidermis, producing an erosion. So we induce an erosion by Nikolsky sign. So if Nikolsky sign is positive, it is good chances the patient might have pemphigus. Then Asmo-Hansen, where uh, we apply pressure on the blister on the bulla, and then the blister tends to move forward with the pressure. So blister can be extended by vertical pressure. This is called Aspo-Hansen sign. So both of these can be seen in a patient of pemphigus vulgaris. So remember these two signs for your exams. Now coming to, we have discussed clinical features. We discussed the signs we can do for pemphigus. Now we're coming to finally confirming our diagnosis. So to diagnose, we do what is called a skin biopsy. Now, the first skin biopsy we do is from the blister. So we take the whole blister, and the second biopsy we do is from the perilesional skin, so from around the blister. This biopsy we send for immunofluorescence, and the second biopsy we send for HNE, HNE staining. The third form of diagnosis is doing a IIF or ELISA, where we check for antibodies. For this, we just collect blood peripheral samples from the veins. Mainly here we are looking for, this one we look for antibodies. Serology, for example, against desmoglein 1, desmoglein 3, or the other antibodies possible. The histopathology and DIF immunofluorescence also we'll discuss in the next slide. So diagnosis, again, confirmed by direct immunofluorescence, which shows IgG deposits on the surface of keratinocytes throughout the epidermis in and around the lesions. Then circulating autoantibodies against desmoglein 3 and desmoglein 1. And then histopathology. This antibody level can also be used to monitor disease activity. So diagnosis is ELISA, immunofluorescence, and then biopsy. Immunofluorescence will see IgG deposited on the surface of keratinocytes. These are all extremely important um, exam questions for your MCQs. Histopathology, the most characteristic three features are acantholysis, blisters, and then this particular feature called row of tombstone appearance. The row of tombstone is here we can see in this. The stratum basale is like, tombstones which we uh, put up around tombs. Um, so straight these kind of fillers along the basal layer of the epidermis uniformly on the base of the blister. This whole thing we see is the blister, which is the blister we talk about here. So this is the blister which appears on the skin as bulla and blisters also. This is Zank smear. So when we take a sample from the skin blister, we stain it and we see acantholytic cells. So here is a acantholytic cell. Now we can see that some of these keratinocytes are sticking to each other, but this one is floating freely. Or this is also an acantholytic cell. So cells that float freely in the epidermis, which are not bound to anything else around it, is also again important question is acantholytic cells in your Zank smear in pemphigus patients. We also do Zank smear for other conditions. For example, in herpes infections, varicella infections, where we'll see multinucleate giant cells instead of acantholytic cells. Of course, in herpes infections, we'll also see blisters. So then this becomes kind of important in differentiating. Okay, so we also talked about immunofluorescence. This is a photo of immunofluorescence in pemphigus patient. IgG deposition we see on the surface of keratinocytes. So these are keratinocytes, and around the surface we can see these green deposits. This is also characteristic called fishnet pattern. This is very important, another important exam question, because you see this looks like fishnet as a whole. So fishnet pattern of deposition is associated with pemphigus, and mainly IgG and sometimes IgL. So we have discussed pemphigus vulgaris. Now we're coming to these subtypes of pemphigus vulgaris, quite rare. Not, I mean, not too much asked in exams, but still, I think you should know. So this pemphigus vegetans is a rare variant. It starts at early age. Pemphigus we saw it starts in middle age. Vegetans starts in early age. Oral mucosa is almost always involved. Lesions on the flexures. There's two subtypes, Newman and Hallepio. Newman, where vesicles and bulla rupture to form hypertrophic lesions. Then Hallepio progress to form vegetative plaques. So we'll look at these here. So this is patient with pemphigus vegetans. This is flexures we see hyperkeratotic. So this is probably the okay. So this is probably the Newman type of pemphigus vegetans where there is hypertrophic plaques. Coming to differential diagnosis of pemphigus vulgaris, so the close ones are acute herpetic stomatitis. So this is herpetic, meaning herpes. We can differentiate based on Zank smear, which we just discussed, where in herpes we'll see multinucleate giant cells, but in pemphigus we'll see acantholytic cells. Erythema multiforme aphthous ulcers, and then oral lichen planus. So we'll look at the pictures separately. So acute herpetic stomatitis, the uh, the stem, your question stem might also have things like fever, weakness, myalgia, painful swallowing. So fever, unlikely, it won't be present in pemphigus. Malaria is also not very frequent. Pain will be present in both of these conditions. Lymph nodes will be present most commonly in herpes. So we can see the ulcers are also quite punched out, well demarcated, and the history is acute. Pemphigus, it is more chronic, slowly evolving. Then erythema multiforme. In this, along with oral lesions, the skin will have target type of lesions, which we've already discussed before. Um, so this we can differentiate based on the cutaneous lesions. Aphthous ulcers again are sharply marginated with surrounding erythema. So surrounding we can see redness and then sharply demarcated ulcer. The pemphigus will have more of erosions and then very not very well defined, very irregular margins. Oral lichen planus will have characteristic lace-work white streaks. So this is also very important from exam point of view. They might give you a picture. This lace work of kind of looks like reticulate, network, violaceous, whitish. Um, this oral lichen planus. Now, differential diagnosis of cutaneous. We just discussed oral mucosa, then cutaneously. Skin lesions can be confused with bullous pemphigoid, which is a subepidermal disorder. This is also immunobullous disease, but this involves the dermis, not the epidermis, unlike pemphigus. All of these are actually subepidermal, below the epidermis. Here we'll have tense bulla, so tense blisters like this, which is bullous pemphigoid, um, very tense looking kind of, and then background reddish rash. These are extremely itchy, might be hemorrhagic also. Then histopathology of bullous pemphigoid. This is the epidermis. We can see this is absolutely normal. There is no issues here. But below the epidermis, there is a whole cleft, big blister, which corresponds clinically to this. Had it been pemphigus, there might be a blister in here, right? But this is bullous pemphigoid, which is below the epidermis. So the blister is here. It's quite simple to differentiate on histopathology. All right. Coming to dermatitis herpetiformis, these are also extremely itchy. Papulovesicular eruption. Distribution is very classic on the extensor surfaces, so knees and elbows. Oral mucosa is not involved. Um, immuno, immunofluorescence will show granular IgA deposits, but in pemphigus we get IgG deposits. Now, treatment of pemphigus, one is topical, so creams, and second is systemic, which is oral medications. When we talk about topical creams, we give potent steroids creams. We recommend good oral hygiene, chlorhexidine mouthwash. Potassium permanganate soaks and topical antiseptics to prevent infections. Sometimes you might have to give oral antifungals if there is also any oral candida. Coming to systemic therapy, for systemic treatment, the drug of choice is prednisolone, which is your systemic steroid tablets. We usually start with high dose, and pemphigus might have to use up to 100 to 120 to 40 mg per kg in severe conditions. Prednisolone, of course, steroids have their own set of side effects for long-term use. So usually we start with steroids, we gradually taper and stop, and then we give things like azathioprine, which are steroid-sparing immunosuppressant agents. The treatment is mainly to suppress the immune system to deplete the B cell antibodies. So anything is mainly immunosuppressant treatment. Azathioprine, we give 2.5 mg per kg per day. Then we can also add tetracycline, so doxycycline. Dapsone can also be added. Other systemic agents that can be used are cyclophosphamide, cyclosporin, and these doses you can just take a picture 1 to 3 mg, 5 mg per kg. Then MMF, mycophenolate methadone. Plasmapheresis, we don't really use it as much. Just remember, this is also a treatment option. Methotrexate is not so effective. High dose intravenous immunoglobulin, IVIG, can also be used. Then biologics, extremely important. Pemphigus, we can use rituximab, which is an anti-CD20 biologic. This specifically depletes the B cells. So there is no B cells, there is no antibodies. So this is also a great treatment option for pemphigus, which we actually prescribe to most of our pemphigus patients. So if in exams they ask which biologic can be used, rituximab is the answer. Now we discussed pemphigus vulgaris. The second important one is pemphigus foliaceus. So the difference is in pemphigus vulgaris, the blister usually forms in the lower level of the epidermis. So 1, 2, 3, 4, 5 layers of the epidermis. In pemphigus vulgaris, which we just discussed, the blistering is usually in the lower levels. While in pemphigus foliaceus, the blistering is high, which is just below the stratum corneum. Stratum corneum is this is your stratum corneum, which is the first layer of the skin. So the blister is just about here. So this is the difference between pemphigus vulgaris and foliaceus. Foliaceus, the blister is on the top. Vulgaris, the blister is on the bottom of the epidermis. Foliaceus is much less common, 10 to 20%, but still quite actually, we do see once in a while in the OPDs. The antigen is against desmoglein 1. So desmoglein 1, which we had discussed in pemphigus vulgaris, the desmoglein 1 and 3 both is present. 1 is mostly for skin, 3 is for oral mucosa. Now, since in pemphigus foliaceus, desmoglein 3 is not affected, there is no oral mucosal lesion. The lesions are mainly on the skin. So, scattered lesions in the seborrheic areas, this is also important. So, the lesions will be in the seborrheic area like the scalp, face, chest, upper back. Type of lesion will be crusted erosions. For example, this patient, let's say, we can see the distribution is mainly on the upper back, the seborrheic areas. And we don't see many blisters because it's on the upper layer. So the blisters tend to rupture easily. Coming to histopathology, okay. So we see this is the lower level. This is not involved. This is the top level. And we see a blister just below the top level epidermis, just below the stratum corneum. So this is the whole blister, which is pemphigus foliaceus. Now these are some atypical variants of pemphigus, which is your pemphigus erythematosus. This is basically immunological features of both lupus, which is your systemic lupus, and pemphigus vulgaris. So ANA is positive in these patients, and then the lesions will be these scaly lesions over the nose and cheeks in a butterfly distribution. Lesions on the trunk similar to pemphigus foliaceus. This we see a patient of Sneer-Usher syndrome, pemphigus erythematosus. I'm not sure if we don't really ask these questions in your NEET exams, but still, for never know what they ask. Okay. These rash you see on the butterfly area of the face. This looks like lupus, and then on the rest of the body we see pemphigus foliaceus like lesions. Now, differentials of pemphigus foliaceus, there's two main differentials, seborrheic dermatitis and impetigo. Now, seborrheic dermatitis will have scaly rash, then will be quite itchy, um, on and off course, but pemphigus foliaceus will be more persistent. Impetigo, more common in children, usually short-lived, can be easily differentiated from pemphigus foliaceus because happens around the lips. So impetigo mainly around the lips, while foliaceus, we just discussed, can happen on the back, chest, and your seborrheic areas. Treatment of pemphigus foliaceus is potent topical steroids, moisturizers. Prednisolone we give in a low dose as compared to pemphigus vulgaris, where we give high dose of steroids. So here it is related to low dose. We can also give HCQS, especially if lupus is coexisting. But remember, the drug of choice is these two, topical and oral steroids. Sometimes you can give azathioprine and cyclophosphamide as adjuncts. Dapsone we can give mainly for pemphigus herpetiformis. So pemphigus herpetiformis is usually where the lesions appear in a herpetiform distribution, grouped blisters. Resistance cases, intravenous immunoglobulins, then mycophenolate, these are all alternative treatments. Prognosis is benign but chronic, responds well but can relapse. The other variants are endemic, which is usually seen in South America because of insect bite, affects children and young adults. Sun exposure causes burning sensation. Head and neck are usually involved first. So this we don't actually, extremely rare in India. Growth retardation is common. Chronic disease is frequent with disseminated varicose veins. Treatment is similar to pemphigus foliaceus, topical steroids, systemic steroids, and then immunosuppressants. This is important. Drug-induced pemphigus. Drugs can induce, which is cause, or sometimes make it worse. So somebody already has pemphigus, it can make it worse. Prognosis, when we stop the drug, the condition also resolves. Mostly is of thiol group drugs. So we'll see now. These are thiol and non-thiol. The thiol, most common ones are penicillamine and captopril. Non-thiol, these plenty of drugs, penicillins, cephalosporins, rifampicin, rifapentine, ramipril, and enalapril. So thiol groups are more common for drug inducement. Because the treatment is stop the drug. Now, SCPD is another differential and type of pemphigus, which again subcornea below the stratum corneum. We see lesions on the trunks and flexures, most common in females. There is characteristic neutrophil collection in the below the stratum corneum, and immunofluorescence is negative. Dapsone works extremely well. So, and then paraneoplastic pemphigus associated with underlying any malignancy. Most common is non-Hodgkin lymphomas. Other conditions that can be associated are lymphoproliferative disorders, thymomas, sarcomas, carcinomas. But for exam purpose, we just need to remember this, that most common is non-Hodgkin lymphoma for paraneoplastic pemphigus. Then otherwise, some leukemias, mostly chronic lymphocytic leukemia, Castleman disease. And so these three, I remember for paraneoplastic pemphigus. It's very resistant to treatment. The antibodies are against plaquin, anti-plaquin antibodies. Treatment we give for pemphigus, almost all types of pemphigus, we use steroids. And then gradually stop and consider things like azathioprine, cyclosporin. The most common cause of death in these patients, mortality in these patients is sepsis, GI bleeds, multi-organ failure, respiratory failure. Okay, so that is, we're done with our intraepidermal Buddhist disorders. Um, these are some MCQs. For example, autoimmune mechanisms responsible for pemphigus vulgaris. So, desmoglein 3 is the answer is because this one is present in the oral mucosa. Desmoglein 1 is present on the skin. This was, if the question was for pemphigus foliaceus, the answer would be A. But for this, the answer is C. Okay, so key distinguishing feature between pemphigus vulgaris and foliaceus. So the answer, of course, is A, because the oral mucosa is not involved in pemphigus foliaceus, but it is involved in vulgaris. If we only done three, remember 3 for oral mucosa, 1 for skin. Right. And then coming to this, okay, so this is a patient with mucosal erosions, and this is a picture of the immunofluorescence. What is the most probable diagnosis? So we discussed these deposits on the surface of the keratinocytes, which we see these green lines. And then we see the deposits are mainly in the epidermis because the dermis is here and this is all black. We see these green immunofluorescent deposits, and the pattern is fishnet. Fishnet pattern epidermis is pemphigus vulgaris. So number 2. Right. So I think that's at the end of our talk. I think we can stop the recording, Manish.
Yeah.